Oh, something's going on here. Oh, that was my phone. Just had a red alert come on my phone there from the government because of the weather.
Oh, that's not where you are, surely.
Yeah, well, this just said it there. It's very dramatic. Anyway, hi everybody. Welcome to this wonderful Facebook Live with Robert Falconer-Taylor. Hi, Robert.
Good afternoon or evening, all wherever you are, and I hope you're keeping safe with the bad weather. I haven't got a red dot on my screen, Andy, that says it's recording. Is that right?
Yeah, it does automatically, so that's all done. Yeah, that's
okay. Good.
Yeah, thank you. Say hi. Hi Ricky. Hi in the room. Say hi. Let us know where you're at as well. And well, we had the joy, Robert, of being at Daniel Shaw's conference in Kent a couple of weeks ago, where we were both speaking. And we were saying kind of off air really that there's definitely a shift going on about our understanding of that was a conference on dogs, but I think more generally with animals, even the things that we're sharing in this group, in emotional wellbeing and animals group, about trying to understand more about the individual lived experience of the animals that we share our lives with. And a big component of that, and you've done this excellent series that I've been sharing in this group and that has been hosted over on ABK and Dog Centre Care as well, on pain, especially thinking about chronic pain. And we wanted to do something to kind of supplement that with this conversation today, to look at pain through different lenses and to consider that both for ourselves through the human lens and also to advocate for the animals that we have around us.
Yeah, good. And I think on the Advent calendar thing, I mean, basically what those are nuggets of misinformation that have been floating around since as long as I've been in this business. So even I've been banging on about this stuff for the last 15 years or so. And yet there are still people, and even people within the animal industries, right across the board from vets right down to trainers, who still have these misconceptions about what pain actually is. And so the idea of this Advent calendar, which is exactly the same as the one that we ran last year, is really to try and get those messages out to the people that actually need to hear them. Social media is great, but the trouble is it kind of goes so far and doesn't go any further. So we need people to share them and share them and share them again, really to try and spread them as far and wide as possible, to get in front of as many people as possible before the next fad comes along and occupies their online space. So that's the idea. We're competing with all this other crap that's out there. So please do share them and let's see if we can get the message out before Christmas.
And they're really important, and it's building nicely as we go through this because obviously they connect to each other. And I think having had my own health challenges this year and how much I've had to advocate for myself, really, it was very much reliant upon the professional who was listening to it, taking on board my own kind of testimony really about my own sensation of what I was experiencing. And I think it's extra challenging when we think about the animals around us as well, when we have to try and join those dots together for them.
Exactly. You're dealing with a non-verbal animal. So I think a good place to start with this, Andy, is I can't resist picking up on the end of life debate that we just had in the Parliament over here. I suspect most of our listeners are probably in the UK, but there will be people catching up from overseas, I'm sure. But if they don't know, we've had this big debate in Parliament about whether it ought to be legalised to have assisted dying, i.e. people have to go over to Switzerland at the moment for that. And whatever your views of that, I'm not expressing a view one way or another, but one of the themes that kept coming up over and over again in this parliamentary debate is that we don't need to have that legalised because there is a perfectly good palliative care system. All we need to do is build up on that palliative care system and make that even better. And if we do that, then an end-of-life experience can be made absolutely wonderful for everybody. And so we needn't worry about having a legalised assisted dying process in place. The fact is that's not true. Palliative care system is as good as it can be, but from the point of view of pain in particular, there are no drugs on this planet that are effective for some of the more ingrained and complex pain disorders that we as sentient beings experience. And of course, we know that animals experience those sort of things as well. So I think a good place to start would be something I borrowed from a series on the radio that was played about 8 years ago, 10 years ago. And anyone who knows Jane Bakewell, who's a veteran extraordinaire broadcaster, writer, wonderful lady, she recorded a series called We Need to Talk About Death, which again was about this conversation of palliative care, and the point is we all have to die at some point, and we want to die, we want to have a good death, not a horrible death. Now, one of the people she interviewed in that particular program was a lady who I'm going to call here Penny. That wasn't her name in the series. Now, she was a lady that in 1998 was diagnosed with cancer, breast cancer. She was treated and she was absolutely fine. And then in 2016, just before this program was recorded, the cancer came back, and Penny had more surgery, she had more chemotherapy. But the problem is the cancer now couldn't be stopped because it had metastasized into her lungs from the lymphatic tissue in her breast area into the lungs, and it was now growing in her lungs. Now, Penny was going backwards and forwards to a GP, and basically she was describing the kinds of pain she was having, and the GP was just fobbing her off and saying, well, just take a couple of paracetamol, that should help with you, help you out a little bit. She couldn't sleep at night, and the way she described her pain was something along the lines of this. She said that she has this dull pain all the time, which she can cope with, but then unpredictably she'll get these sudden waves of pain that will rise up, and the only way she can describe it is that it feels like somebody's sticking a hot knife into her chest, right the way through her chest and into the back of the chair behind her, and she feels like she's been immobilized and pinned to the back of a chair with this knife. And after 30 seconds, 45 seconds, or a minute, or whatever it happened to be, the pain would gradually subside and she'd be able to move around again. Now, these spasms started off fairly infrequently, but they were getting worse and worse over time. And that's the point where her medics started to take her seriously after she'd had all this suffering for months and months and months, where it really was beginning to get intolerable for her. And shortly after that, she went into palliative care. She was put on opioids, which helped a little bit. They didn't take the pain away completely. The side effect of those, of course, is she spent most of her time in a kind of daze and not really conscious and not able to do anything anyway. So it's just sort of heavily sedated. And she died probably, I think, about 5-6 months after that. And that was the end of that. And I think that's the kind of fairly poignant story that we see in veterinary medicine as well. We do see dogs with these very complicated cancers. One of the most common cancers in dogs is osteosarcoma, so that's a bone cancer, and that tends to spread or metastasize fairly early on in the course of disease. And of course, you get metastases in the lungs and other parts of the body organs as well. We have no idea how they feel, but we can be pretty sure that they're going to suffer the same kind of agonizing pains, so chronic throbbing background pain, and then maybe these stabbing, nasty, sharp pains like being stabbed by a knife, as Penny did. But of course, they can't vocalize that. So I think that's a really good starting point to start thinking about pain. Now, the question that always interests me is that how did evolution evolve these complex, apparently maladaptive and completely useless pain syndromes? And I think if one goes way back in evolution and traces it back to how we evolved, we originally evolved as organisms living in the sea. This is before we developed skeletons. And if we turn the clock back in time, we can go right back to something like about 600,000 or 600 million years ago, in fact, 600 million years ago, where we were animals like sponges who were just rooted themselves on the bottom of the sea, and they were filtering their plankton and stuff from the water. And at some point or other, as they evolved and evolved and evolved, at 400 million years ago, which is about 200 million after the sponges were there, we had the evolution of vertebrates. And they evolved in the water first, and then they crawled out, and we got the amphibians, and we got the reptiles, and mammals came along at about 60 million years ago. But so even back as far as 400 million years ago, we had vertebrates. And the way I see it is that we had very primitive immune systems which were developed around the gut in animals like the sea squirts that lived at the bottom of the sea. All they had was guts, they didn't have brains. So they had to have immune systems around there to protect them from invading bacteria and that sort of thing. When we became vertebrates, what appears to have happened, as far as I can see, is that our nervous systems, or at least our immune systems, got split into two. So we have one immune system in our body, in our bodies, and that's particularly big around the gut. So everybody talks about the gut microbiome and all that kind of stuff. The most important component of the gut microbiome is actually the immune system that's all integrated with. But then we've also got a separate immune system which lives in the nervous system. So when I say the nervous system, I mean both the brain and the spinal cord. Now, the reason that the immune systems have to be different is because once you develop a brain, you can't have all things like blood vessels and complex lymphatic system and that sort of thing to transport the immune cells around the body. In the body, we've got blood and the lymph and all those sort of things. In the brain, we simply don't have the real estate for that. And so if we look at all of the cells in the nervous system, only about half of those are actually neurons. Humans have about 86 billion neurons, but there's also about another 85 or 86 billion cells which aren't neurons. And what those cells are called glia. The word glia basically comes from the word glue, from Latin or Greek or something like that, because that was the stuff that seems to stick everything together. But in actual fact, the glia is made up of two kinds of different types of cells. One are the astrocytes, and the other are the glia cells, or the microglia cells. The microglia are basically the immune system of the brain. So the brain has a complex immune system, and the thing is the two are connected to each other. And what can happen with complex pain syndromes is that the inflammation of pain, because pain is an inflammatory disease, it certainly starts as that, as you'd know if you put your foot on a tin tack and you can feel pain and the inflammation and the soreness, and that's all part of healing. But what can happen is that initial inflammation can basically become maladaptive and spread up into the nervous system, and that seems to be responsible for these complex pain syndromes that we see. So if we dissect that a little bit further, in terms of classification of pain, there are basically three different types recognized in medicine. First type is called nociceptive pain. And what that is the kind of pain that you experience if you put your foot on a tin tack, or let's say you stand on a rusty nail in the garden or something like that, you get an immediate sensation of pain. You know where it is, and that pain signal is simply telling you where it is, what the location is, and you need to get your foot off that nail and move somewhere more safely. What can happen? Let's say that in normal circumstances, if you sit on a nail or something like that, the wound is fairly simple. You're going to have a really sore toe for a week, 10 days, and then it's going to heal up fairly quickly. And after a while, that pain will disappear, and you might be left with a little bit of a scar in the skin. But let's say that nail penetrated a little bit deeper, and it happened to scratch the surface of one of the joints in your toe, and it breached the bursal membrane of that joint, and it made a little mark inside the cartilage, and it damaged a little bit of the cartilage in that joint. What can happen there is, because you've now broken into what in effect is a very complex organ, and the way to think about joints, a place where we get osteoarthritis, and there's a lot of talk about osteoarthritis in dogs, a joint is in fact an organ, and all the joints in your body are different organs of the same makeup, and they are highly complex. They have their own metabolic processes, etc., of healing and regeneration. And what can happen when you get a little breach like that is you can set up a cycle where healing just stops happening particularly well, and you get this constant cycle of degeneration, regeneration, degeneration, regeneration. And what can happen with that is that it can set up a cascade of signals which travel up from the toe and into the spinal cord, into the dorsal root ganglion of the spinal cord, which then transmits the pain information to the brain. Within the spinal cord itself are a lot of synapses, and on those synapses are lots of descending and ascending pathways to and from the brain, which basically regulate or modulate those pain signals as they go up and down. And they do the same thing. If you're sitting in a chair watching this and your chair is not particularly comfortable, or you're wearing a very prickly jersey, you may have noticed or felt your prickly jersey when you're sitting there not thinking of anything else. But now you're so enthralled and so excited and engaged in the talk that you're hearing now that you've forgotten all about the prickliness on your skin of your uncomfortable jersey or your uncomfortable chair. And that's because you've got these inhibitory modulatory signals from the brain going down and cutting off those touch signals going up to your brain. They're supposed to do the same thing with pain. But what can happen when you've got a continuous flow of signals going from the site of injury into the spinal cord is that the spinal cord can become maladaptive. The synapses in the spinal cord can become maladaptive. And this is to do with those microglia cells. And you can start to get amplification of those signals because the synapses that are supposed to be inhibiting those signals start to grow and become strengthened. So in effect, what's happening is that your spinal cord, those synapses in your spinal cord, is literally learning, like teaching a dog to sit or stay. They remember those, they remember how to do that. They remember what the signal was. Exactly the same process of long-term potentiation is happening in the spinal cord. And what that kind of pain is called is neuropathic pain. And it comes from the term neuro, which is obviously to do with the nervous system, pathology, which is to do with disease. So basically, it is a pathology of the nervous system associated with pain. So that is a maladaptive kind of pain. And as time goes by, those synapses can become stronger and stronger and stronger if the original injury isn't addressed properly, which could mean some kind of intervention. It could be done with drugs and those sort of things. But what can happen if that is left in some cases is that the pain signals that the brain is now receiving start to cause shifts in the way the networks in the brain are actually working. So there was a new category of pain added just a few years ago. It's about 4, 5, 6 years ago, and it's been modified and revised a little bit, and that's called nociplastic pain. Now, the definitions you'll find for this are quite varied and sometimes contradictory. But for me, what nociplastic pain is that it is pain that has actually jumped out of the nervous system or out of the pain pathways completely. And what it seems to be doing is reprogramming certain networks in the brain that are involved in processing cognitive processes such as social interaction between species, processing the kinds of signals that are coming in and allowing the animal to process or us to process whether we think it's important or not. And the two networks that have been shown consistently and reliably to be affected by these kind of pain signals is the default mode network, which many of you may have heard of. If any of you have done meditation or mindfulness and those sort of things, what they tell you is that your default mode network is the one that's, if your mind is really, really busy, it gets switched off because it's giving way for the other networks to take hold of the task. So while you're listening to my talk now, your salience network, I hope, is turned right down. If it isn't, then that means you're not taking any notice of what I'm doing, and your mind wandering off and thinking about what you're going to have for supper or what you're going to watch on TV. We don't want that. So the default mode network does that, and what these pain signals do in nociplastic pain is interfere with that. The other network they interfere with is the salience network. Now, anybody who has experience with training dogs and those sort of things knows that what we do when we train a dog, we have to engage a dog. And what we're doing is providing signals which, for the dog or for the animal one is training, have some importance. And so that's what salience is. Its importance is attention. So these are the dopamine pathways we're talking about. We're talking about basal ganglia, striatum, dopamine pathways of attention. Yes, I can see that. Something's happening over there. I need to attend that. That might be danger. It might be something you want to avoid. Maybe like keeping an eye on the weather. If you're living anywhere near the places where you're going to get these red weather warnings coming in the southwest of England. So your salience network should be tuned into that. So what happens with these nociplastic type pain is they take over these networks and they start to generate pain out of nothing, if that makes sense. So they become completely detached from the original site of injury, which might have healed up and gone away. They become detached from the neuropathic pain, which was started in the spinal cord, and they start to set up almost like phantom pain, if that makes sense. So there's nothing there which is creating the pain. But if one bears in mind that the sensation or the nasty sensations of pain are actually created by the brain, not by the injury itself, that suddenly makes sense. So what we have here is a situation which explains some of the really complicated pain syndromes that we understand and we recognize in people, but we have yet to identify because we really haven't looked for them in other species of animals. Anyone who is familiar with conditions like fibromyalgia, some of you may have fibromyalgia, or you may know somebody who has fibromyalgia. And it's one of those conditions where you probably, if you have had it or got it, you might have been fobbed off originally by your doctors because they can't find anything wrong with you. They can't find any lesion, they can't find any cause of why you have these pains, which seem to arise from nowhere in particular, but they're very real pains to you. This seems to be what this nociplastic pain is. Now, there are a couple of examples. I kind of dug around the literature to see what I could find. And one of them was obviously the kind of pain that Penny was having with her cancer pain. That probably weren't lesions where she was having the pain, but basically her brain had rewired her networks in her brain to start feeling sensation from those places. And so, there's nothing you can treat because it's not really coming from any particular focus. Any of you who are physiotherapists, veterinary physiotherapists, or sort of myotherapists, or even T-touch practitioners, you will have heard of myofascial pain or myofascial pain, which is a kind of, it's nothing to do with facial as in faces, it's to do with muscles and the connective tissue between muscles, which is the fascia. And certainly if one practices acupuncture, one of the things one targets are these acupuncture points or trigger points inside the muscles, and you can stick needles into that, and you can often disperse that kind of myofascial pain. So physiotherapists take note. You might actually be dealing with a complex pain syndrome in the patients you're seeing. And as I say, they can be really difficult to resolve. I think a prime candidate in veterinary medicine are cats with what used to be called idiopathic cystitis, but we now call it interstitial cystitis. This is something that humans have as well. So any human that's had interstitial cystitis, it's an unexplainable, incredibly painful, irritated feeling in the bladder. Irritable bowel syndrome is another one. We haven't identified, or we don't label irritable bowel in dogs. We certainly have some inflammatory bowel disease in dogs, which seems to mirror irritable bowel disease in humans. So, and I'm sure there are others that we'll be able to dig out. So, although there isn't a literature on this in non-human animals, we're certainly going to be finding more of these kind of cases of this neuroplastic pain as we move forwards.
Yeah,
so
can we pause there a second, Rob?
Yeah.
On that, because because even with seeing a doctor with some of these things, as you say, we can easily get dismissed sometimes because if they can't find that kind of focal point where they might identify the pain coming from. And obviously we have the benefit of being able to say, yes, but I feel it.
Like Penny.
This is the challenge.
Like Penny with cancer, it is.
Yeah, indeed. And this is the challenge, I guess, when we think about, because I worked with a dog going back a little while, and amazing physio that I worked with found that there was neuropathic pain there.
Well, it might not be neuropathic, it might be neuroplastic.
Exactly, that's the point. Yeah, I think the nociplastic comes to mind with this thing, but that particular vet didn't even think that the neuropathic pain was a thing for dogs, because he felt that they didn't have the same regions that we do to be able to have that from a kind of processing point of view.
They have a spinal cord.
So how will we find the way of finding out more then from animals that they might experience some of these kind of more, what we might class as an idiopathic kind of thing, or the nociplastic side of pain?
Well, what I do if I'm discussing it, when I was a vet, I'm not in practice anymore, but when I was a vet, the kinds of discussions I would have, I will share with you now. But the kinds of things, I think the important thing is to actually get the carer or the owner or the pet parent on board with these. If you're a practitioner professionally in the pet industry, or if you're an owner, pet carer, pet parent listening now, the kinds of things I would want to do is try and break it up into small bits that are intelligible and one can think about in one's own pet. If you've got the pet in front of you, or you're living with that pet all the time. And this could be any, remember right at the beginning, I mentioned vertebrates, which includes, as we're on the Pet Remedy channel here, not just cats and dogs, but birds and reptiles and all the other kinds of animals that people have as pets. We have no idea what their pain experience is. But startling thing is, what we know is that in all the animals where we've actually looked, all the vertebrates that we've looked at using imaging technology, they all have default mode networks and salience mode networks. Now they're all doing something in their brains. They're all processing the signals in a way, in a similar way that we do. What they do with the default network, I'm not sure. I don't know if they go, to states of mindfulness and those sort of things. They certainly have salience networks. Dogs and mice and rats certainly have default mode networks. We've got all the evidence for that. That's been demonstrated many times using MRI scanners on these animals, fMRI scanners. I think it was Jeff Burns did quite a lot, and lots of other people. Yeah, there's lots of other people that have done the same thing. But we've no idea what the experience of animals is. But I think we need to apply the precautionary principle here that Jonathan Birch applies, which is we have to assume they do until we're proved otherwise. So these animals have complex brains. Their brains are completely morphologically and topographically identical to ours. Ours may have more neurons. We have more neurons than an iguana, Andy, or a mouse, or any of these other animals. But that doesn't mean that they don't have emotional experiences, and particularly aversive emotional experiences, in a similar way as we do. So the way I explain this to interested parties is something along these lines. And this is taken from Samantha Lindley's work. She wrote a great book on rehabilitation, palliative care, published by the BSAVA in 2010. I think that was published, so 15 years ago. Sam Lindley's a really great person. She taught me acupuncture way back in the olden days. So that was when these things were just kind of coming online, and it was just beginning to be practiced in veterinary medicine. And she was great, and she still practices, a fairly holistic kind of medicine now. So she's kind of worth looking up. She was speaking at the conference last year, the pain conference, the campaign conference. So you can pick up, if you've got the recordings of that, go and have a look and see what she was talking about. It would have been this holistic approach. But anyway, kinds of things that she uses, and I use different names for them, is there are basically 4 domains of pain. First one is the sensory one. And, whenever one is looking at one's animal or advising a client looking at an animal, or as a physio or vet looking at an animal, pain isn't a single thing. It's made up of 4 domains. The first is sensory information, and that's really when we put our foot on that nail and we get that sensory, sudden sensory feedback of ouch, withdraw. And those are the A delta fibers. So that's the kind of obvious one. And that is not necessarily suffering. That's, it might just be an inconvenience. You certainly find humans and dogs that are running around chasing balls, they can break a nail or something and they have the ouch, but then that doesn't interrupt their fun of chasing the ball or whatever they happen to be doing. The second one is emotional. And so that one comes a bit later. And that one is broadcast by the C fibers, the slow unmyelinated fibers. And what they do is they convey information up to the more limbic or the cortical limbic areas of the brain, such as the insula, the anterior cingulate cortex. And they're not the ouch, it's down in my toe. They're, Christ, that hurt. That was horrible. And that's the kind of ooh, it'll make your heart rate go up, and your breathing go up. And if it's painful enough, it might even make you feel sick, or you might even vomit, because it's so painful, emotionally painful, not physically painful. So that's the emotional one. The third one is really, really important. And this is the cognitive one. And this is the one that's slightly more difficult to define, because it's beyond emotions, and it's how that emotional pain affects you in the longer term. And I'll come back to that one. And the last one is basically a behavioural one. So the four domains are the sense, what the animal felt immediately, and what causes the foot to withdraw from the sharp stimulus. Second one is the emotional, which is the oh Christ, that hurt, that was horrible. The third one is the cognitive, which I think feeds into the nociplastic type of pain in the long run for a dog that has a really poor state of living and is clearly has poor well-being and is not happy. And we'll talk about that and talk about it together, I think, Andy. And the fourth one is the behavior, which is basically what the owner sees. Has the dog got a limp? Of course, this is really important because it's what the physio sees, and it's what the vet sees. If you take the dog down to the vet, has the dog got a limp? Does the dog squeal in pain if I push this part of his anatomy or twist this bit of the joint? And so that's just the behavioural side. And sometimes people get confused and think that's all there is to pain. There's a pain, and then you get this behaviour, which is either there or isn't there. And if the pain's not there, or if the behaviour's not there, that means the pain's not there. And what I'm saying is it's really important to keep these things separate and think about them separately, because just because the dog isn't limping doesn't mean that dog's not in pain. Okay, does that make sense? So that's why it's really important to separate them out. So I've talked a little bit about the sensory discrimination. I'm not going to cover that again. The emotional side, we can expand on a little bit. I'm going to skip over that for now because we'll suddenly run out of time. The behavioural domain, again, is what we see, which is separate, importantly, as I said, from the emotional side and the sensory side. It can be decoupled, i.e. you can not limp and still experience pain, and vice versa. And the one which I want to spend most time on is this third one, which is the cognitive domain. Now, the cognitive domain is the one that an animal and we engage in when we are using our default mode networks and our salience networks. Our salience network is the one that focuses our cognitive. What am I going to do now? How do I feel at this moment? How's my day been? What's my lifestyle like? So your salience network is going to be influenced by all those things. So, for example, a dog that is left at home a lot on her own, and she has separation problems, her focus is going to be what her caregivers are doing when they're around the house, and worrying about the kinds of cues that she's going to see when her carers are going to shut her own, leave her home again and go off to work. Or it might be a dog that's worried about noises, particularly this time of year with fireworks and those sort of things. So the overall well-being and the expectations of the animal are really, really important, because they drive what the salience network is going to be focusing on, if that makes sense. The salience network can't focus on too many things at once. It's either going to be focusing on, oh dear, it's getting dark, am I going to hear fireworks? Or it's going to be focusing on, am I going to have a game with my carers tonight? Are they going to get the toy out and play with me? So it all depends on that animal's experience, what the salience network is focusing on. This becomes really important, because if we've got an unmanaged chronic pain problem as well that may not have been diagnosed or not recognized, certainly by the vet, as is your experience, Andy, and many others of us as well, then that might be something that's rumbling along underneath, and we might have a case of this kind of nociplastic type pain. It's there and mucking up these networks even more. And the other side of it is the default mode network, and this is the network where the animal is then deciding on what to do. the kinds of things it wants to engage in with the owner socially, with the food. And so it's a kind of backup, if you like, or the engagement side of the salience network. And I think where this becomes important is if we think about an animal that has a really good quality of life and whose well-being is in good shape, compared to one that isn't, where they're left at home a lot, they don't go out with much interaction for walks and stuff. They may even have an aversive trainer who sort of jerks them around and pulls them around. They don't necessarily have a particularly good relationship with the people in the house because there are too many people. There are kids coming in all the time. They don't get enough sleep. Kids coming and going, and loads and loads of interruptions. The kinds of mood state they would have, i.e., their cognitive processing of challenging and aversive information, such as a grumbling pain in the background and other problems they may have, is if you think of two people, let's take two women, and I'm choosing women deliberately because one of the women in this hospital is somebody who's got severe labour pain. She's having a baby. She has severe labour pains, and she's in one end of the hospital in the labour ward, and she's screaming out and wanting the gas and all this sort of thing because her, the contractions are so painful for her. And at the other end of the hospital in the cancer ward, there's another lady, same age, same type, but her problem is she's got terminal cancer, which is affecting her uterus. She's one of these poor souls that's contracted a nasty terminal cancer fairly early on in life, and but her experience of pain is pretty similar to the woman who's having the baby. And the question is, and this is the question I would pose to a caregiver, is who do you think has the worst pain? Pain, as far as their sensory experience is concerned, is the same. Pain, as far as their emotional experience is concerned, i.e., God, that hurts, that's nasty, is the same. Their pain behaviors might be the same as well, i.e., they don't want to move or they're riling up in agony. What's different is their processing of the cognitive side of the pain. Does that make sense? So it's their experience, that background information that influences the kind of pain they're getting. So I think this is where I start thinking of your work, Andy, and Sarah Fisher's work with her free work, where what one is doing is really building up resilience in pets. Whatever their problems are, whether their problems are external, such as noise phobias or separation problems, or some kind of dysregulated relationship with the people in the home, a misunderstanding. I think what Sarah does with her work and her free work is she takes those dogs, which are really vulnerable, so their cognitive processing, their cognitive modality is vulnerable and really not functioning well, which means the salience network isn't functioning well either. And what she does is basically give them the freedom of choice. Choice is really important when it comes to the cognitive system, because the animal starts to learn that actually they have got choice, whether they move towards something, move away. They've got freedom of choice to do things which aren't necessarily pain invoking, like somebody with a dog with arthritis who insists on taking the dog out for the same walks all the time. The dog must get out, exercise, and often the veterinary advice is one does need to exercise the dog somewhat because you need to build up the muscle. But and then some people with spaniels, I'm a spaniel man, Springer Spaniel man, and if you have those sort of dogs, you think, Christ, what the hell are you going to do if they have an injury? Because those dogs need to get out and they need to run. But of course, that's not true. We know that's not true. And come to the kinds of things that Sarah teaches. She puts these dogs through this kind of free work program where actually, in actual fact, what you're doing is giving the dog a lot more choices. And I think this is something that you and I were talking about before we came on air, Andy, the idea of choice, where we're not just feeding the animal or giving the animal what we think we want it to learn or what we want it to do. We're actually giving the animal freedom to work within its own space, if that makes sense. So what Sarah does with her free work is that the animals can explore new places. If it's a cat, you put out empty cardboard boxes and all those sort of things that they can go and explore. Mice and rodents, all those kind of animals are incredibly inquisitive. You give them somewhere to explore and they'll be off. and there are new something in the cage, bigger cages with hidey holes and all those sort of things. I don't know about iguanas, but I suspect they are quite curious sometimes once they warm themselves up a little bit. But the whole idea of this kind of free work, sniffology, those sort of things, really, really important. So I think for me, if one picks up on those four domains, the sensory, the emotional, the all-important cognitive, and the behavioural, I think it starts to help people understand the kinds of things they need to think about if they've got a dog with chronic pain syndrome, which could develop out of some unmanaged or unmanageable condition like chronic osteoarthritis, which is one of the most common diseases we see in dogs, particularly younger dogs. And as I said at the beginning, remember that a joint is an organ. It's not just a simple hinge that you can stick some WD-40 into. It's an organ. It's got a whole organ system in it, and it's very, very complex. And it very quickly leads to neuropathic pain. And my suspicion is that if these things are kind of unleft, and on top of that, if that dog is having not a particularly good lifestyle, which is our job as canine professionals to make sure that the dogs are doing the best they can, they're building resilience all the time, which people like Kathy Murphy talk about a lot. And if you're a resilient dog, you're going to be less vulnerable when the shit hits the fan with whatever in life comes to hit you. You're going to be much more robust to cope with that. So I think I will leave it at that. The only other thing I'll put in here is that I like to encourage caregivers, owners to think about a kind of triangulation between the information that's at hand about a dog's condition or a cat's condition or a mouse's condition or whatever it happens to be, whether that's a condition of pain somewhere, or whether that's a condition of illness, or whether that's a condition of anxiety for some reason because they're frightened of fireworks or thunder or something. That's the overall knowledge about that dog's potential cognitive concerns, the things that are going to be worrying that dog about its well-being. And then within that, there's going to be what the vet knows, which is going to be mainly from that behavior domain, because that's what the vet sees when the animal goes to the vet. He has no knowledge of what's going on at home. And then there's the all-important knowledge of the caregiver herself or himself, because they're going to have knowledge of, my dog, I think, is just a little bit off. Cat's a bit hidey today. He's not as exuberant as he was yesterday or last week. I just get this feeling there's something not quite right. And I think, from my experience, sometimes it's very difficult if you're in a really, very busy surgery and you're a veterinary professional and you've got your 10-minute consult and somebody comes in with an animal, you can't find anything wrong with it. You can't find anything wrong behaviorally. You've examined the animal all over, but the client says, but there's something not quite right and I can't put a finger on it. To me, that's golden information. It is really, really precious information. And I think as behaviorists and trainers and physios, we need to be on the ball with that as well. Don't dismiss what the client says. There's this old cliche about having, is it 2 pairs of ears and 1 set of eyes, or it's 1 mouth and 2 ears, isn't it? So you need to use some of that proportion. You need to be listening to what these people say and pick up when an owner's trying to tell you something, because often as a professional, owners are quite shy and they're worried about showing that they're ignorant, if that makes sense. They're worried about showing that they don't have the knowledge, and they respect people with knowledge. And I think as professional people, we need to be very mindful of that and allow the owners to speak and encourage them to say, try and unpick what they mean by this not quite right. Because for me, the not quite right, but I can't put a finger on it, is a hallmark of a problem in that cognitive domain, which could be pointing us to one of these complex pain syndromes, which might be something to do with this nociplastic, pathology that we know exists now. So I think I've probably said enough. I could say loads more, but maybe we can play around with that a bit, Andy.
Yeah, I've got a few questions from the comments actually, which we'll come to as well before we finish. And I think it's really interesting, especially the cognitive side of things, because at the conference I was talking about about the importance of social safety and and the role of social pain actually, and how we recognize how much that affects physiology. And there's high numbers of people who are, would be classed as being lonely, and their propensity to have different things, and even how they experience pain. So those people who have a secure social network seem to experience pain in a different way to somebody who doesn't. And I
Yes,
think this is
exactly.
that thing about when you think about resiliency, this notion of bouncing back, as people call it, or coming back to that place. It depends on what place you started from in the first place, of course. I think this is the key.
Absolutely.
So resiliency isn't actually about soldiering through stuff. It's about
No,
our starting point, really, and how we improve
it
that.
is. Yes. And early life experiences, all these things come into play, as Kathy Murphy clearly points out. Often with what we have, we can't undo the past. I'm in rescue. I've always had rescue dogs, and I certainly can't turn the clock back to when they're 8 weeks. I wish. So you're absolutely right. We have to work with what we've got. But at least I think if people who are responsible for the welfare of that animal at least know, we give them a starting point, and we can give them those 4 domains. Those are what we need to be looking at. They don't necessarily have to refer to pain, by the way. You can refer those to anything. A dog with separation problems, a dog that's frightened of loud noises, a dog that doesn't like other dogs because they've been poorly socialized. Those 4 domains fit with that as well,
Yeah.
not just pain. So you've got the sensory, so how the dog reacts when they see it. That would be a dog if they're frightened of other dogs. The emotional response to that, which is the immediate, the cognitive response, which is what comes later, and the emotional response feeds into that, good or bad. So you've got plus things going in, less resilience, plus things going in, more resilience, minus things going in, less resilience, more vulnerability. And then you've got the behavior, which is actually what you see. And the mistake most people make is they concentrate on the behavior, which is what I hate about this applied behavior analysis, because you concentrate on the behavior, but that's only 1 domain out of 4.
Well, that's our point of a lot of stuff that we talk about, of course, and many other people to try and push away from, just because a lack of behavior does not denote a lack of suffering, and vice versa.
No,
And I think again, this goes back to this thing about what we can do when we know for sure that choice and agency, and an element of control over outcomes or predictability over outcomes, and also for a social species being supported by what are supposed to be our secure base, have a huge impact on our resiliency. And also, when we think about, you mentioned earlier about mood state. About where we are more foundated in that mood state, whether we have that more optimistic bias or pessimistic bias, all these things.
Yeah, a lot of work. Mike Mendel, a lot of work on judgment bias. New paper that's just come out today, funnily enough, which I think, was it in mice? It's some species he's not done before, but it's the same thing, the same kind of things he's picking out on those. So interesting. Yeah, sorry, I divert.
No, but I think it's interesting because what we're adding here is an extra dimension to considering pain. I think this is the key. I think, especially for us, recognizing more and more the important role of the behaviorist and trainer actually understands these things. And I know there's been a lot of work with people with fibromyalgia looking at other areas to support how that kind of resilience for what they're experiencing, and with some success actually. And invariably it is about looking at shifting some things around mood state and connectivity with kind of environment, social, and other.
I agree, and the reason is because there's no lesion. The lesion is in the networks of the brain, and those networks have been damaged by resynapsing and reconnecting. The beauty of the brain is you can actually undo that and reconnect them again. And certainly we now know that a lot of people with ongoing PTSD that's never been resolved, childhood abuse and those sort of things in humans, can come back and manifest themselves in complex pain syndromes like fibromyalgia or like some of these other things we've been describing, these undiagnosable kinds of pains. And it might not even be you experience it as physical pain. And actually what it is emotional pain, as you say. But the thing is, your brain can't differentiate one from another because the networks have been screwed up. And that seems to be what it is. As I say, we now have evidence. We got imaging evidence that these networks are damaged by this other kind of pain, which might not necessarily originate from physical trauma. It might be emotional trauma.
And actually, when you think about it, when we think about the kind of role of pain, which is, the body, the system is under attack here, or there is something that you have to be mindful of and needs to be kind of healed or cared for. A lot of those systems, as you explained at the beginning, they're very intertwined: physical pain,
Yes,
emotional pain, social pain.
Yes, they are. And I think it seems to be because my theory, and I have nothing to prove it, or my hypothesis is it's basically because when we became vertebrates and we grew brains and complex nervous systems, our part of our immune system was engulfed by that. The immune system was never designed as an emotional system. It's designed as inflammatory, then anti-inflammatory. But the circuits have been repurposed for a brain. And one of those things, which is another hook, which I think is important, is we keep going on about the importance of tryptophan in the diet and serotonin and microbiomes. The link there is that tryptophan is a precursor of both anti-inflammatory and pro-inflammatory cytokines in the immune systems, in both immune systems, in the immune system in the body and in the brain. And we know that if one is cognitively out of balance, i.e., one's mood state is poor, we have anhedonia, we're not happy, we struggle a lot emotionally, what happens is that we hear these people go on about, oh, you've just got to have all these tryptophan supplements, blah blah blah, and you'll be fine. You'll get more serotonin, that'll make you feel happier. That's bollocks, because what happens to that serotonin, what happens to that tryptophan, I beg your pardon, is it's split up by about 1% to 99%, or maybe 3% or 5% to 95%. 95% goes to the immune system in the body, i.e. not the brain at all. The other 5% goes to the brain. Some of that gets converted to serotonin. But if you are disordered in mood, what happens is that then gets converted down the kynurenine pathway, which is the inflammatory pathway. So the two are intertwined. The original serotonin system is part of the immune system, had nothing to do with emotions and feelings. And so it seems that the bit of immune system that got commandeered by the brain, it's quite a big chunk of it actually, still runs on tryptophan, as does the body one. And the problem is that evolution is using the same precursor amino acid, both the emotional side and the immune side. And so if our immune system, because all mental disorder, all mental disquiet is inflammatory by nature, because of these microglia cells, all that tryptophan just gets nicked by the pro-inflammatory side of that, and you produce more of these pro-inflammatory cytokines. So it doesn't end up as serotonin anyway, so it's a myth. So it's another one of these things that's got into popular culture, which is quite nice to burst the bubble on.
I think that's a really important one, because there was a big thing about kind of serotonin-based diets. With the tryptophan, with tryptophan, that kind of thing. I think, like you say, it's relying upon a system that's already working well and is healthy. But when not, then these things change.
Exactly.
And what the body thinks it needs, because obviously the body is, I'm guessing, considering, well, we need more ability to deal with inflammation, with the protection side of things, hence the dialing up of the inflammation system. Fascinating. Right, I've got some questions for you, Robert. So that are here in the group. So does this possibly so I think we're talking about the kind of nociplastic pain here. Does this possibly explain so-called phantom pain from an amputated limb?
It can do, actually. That's one of the things on the list. Phantom limb is definitely neuropathic, because what's happened is that the original injury on the limb has already migrated to the dorsal horn of the spinal cord in the back. So even if it's your toe, it's gone into the back, and that's neuropathic pain. But the nociplastic pain can derive from that. Yes, if it's something which is ongoing and continuous, and certainly the way we treat it, phantom limb, I used to use amitriptyline quite a lot, in the old days, and we used to give it prophylactically in some animals, actually, particularly with cats with mutilated tails, because of cat fights or car accidents. You give them amitriptyline. It's very, very difficult to give. It's very bitter, as a kind of prophylactic, and that's something basically I learned from the doctor. The doctors handed out with things like shingles as well to stop a neuropathic pain developing in shingles if ever you had shingles. So it's one of these things that seems to block it. And the way it's blocking it is because it's actually working on the cognitive side of the brain and stopping what we now believe is probably more likely to be nociplastic than neuropathic, if that makes sense.
So, do you think we should be looking at more prophylactic ways of dealing with animals in the vets when we think about possible, rather than just seeing it as relief to pain now, seeing it in a way of thinking about the pain that might come, especially the neuropathic stuff, or even the nociplastic pain?
I think it's tricky because if you've got an animal with let's say arthritis, osteoarthritis in the stifle joint or something like that, or in the shoulders, both common areas, I believe that the way that disease progresses as a physical disease and whether you get these complex pain syndromes probably depends quite a lot on that animal's overall mood state over time as well, and lifestyle and how frustrated they are and their upbringing and all those sorts of things. And certainly in the human field, there's no way of being able to intervene prophylactically to stop a potential nociplastic condition occurring. It's one of those things that you only know it's going to happen when it happens. Right. But my belief is that if one has a much more holistic approach as the caregiver of that animal, i.e. you're not relying totally on the vet to dispense you with medications or surgeries or any of those sort of things, all that sort of thing, which is what a lot of owners do. They rely far too much out of, dare I say, I don't want to use the word lazy, but maybe because they don't feel empowered to do anything. And that's why I think this four mode, this sensory, emotional, cognitive, and behavioural dimensions of pain is really useful, because it then gives a window into empowering person responsible for that dog's sort of everyday well-being to think about engaging in. And that's why I come back to Sarah's work again, because there are easy exercises you can do. There's loads and loads of stuff on YouTube there. Maybe we should get Sarah involved in a conversation like this at some point and see if she could put a plan in that we could then develop as a system to put out there to prospective people who need it.
I think getting you and Sarah to come, maybe this is more of perhaps a dog centre care chat, but maybe here, who knows? But I think getting you and Sarah in the same space would be amazing. So we must do that, because I think we bounce off each other very well. Another one here: if a dog is limping, is there always pain?
There is certainly a situation where you can have a stifle joint that's been so damaged that there's no cartilage left in it, and it becomes a mechanical problem where the dog can't physically move the joint. But I would always want to give the dog the benefit of the doubt,
right,
about whether there's pain there or not, because even if you can't elicit pain in that joint, that doesn't rule out the fact that you might have neuropathic pain, and still pain signals being amplified up into the brain. But the dog just gets used to it. Right. And I've got arthritis in my ankles. I've got arthritis in my thumbs as well, and it's a nuisance. But I'm not moaning about the pain all the time. It only hurts me when it gets cold, or when I'm upset about something, or at night it'll wake me up. But it's not hurt. It's not. I know the pain's there, but it's not necessarily bothering me, because my well-being is enough. So I'd be really careful about ruling out pain in a dog that's limping. We don't know. Give it the benefit of the doubt. Jonathan Birch every time. Benefit of the doubt.
Dawn says, she feels a bit uncomfortable sometimes with seeing vets manipulating legs, for example, in an animal to see about pain. Is it always 100% necessary for this manipulation to be done when the dog is in pain already?
The trouble is, you don't know how far to flex or extend a joint until the dog reacts, and it does yield a lot of information. not inflammation, but information,
Mhm.
in case anyone missed that. And of course, the dog would be injuring the leg anyway.
Mm.
So I would rather elicit. I would rather know if I was examining a dog, which I don't do now because I'm not in practice. But when I was examining dogs, I would want to elicit that pain because it is information for me,
Mm.
confirm pain. The worry for me is if they don't elicit any pain at all, even though the dog may be feeling pain, the dog is too stressed in the surgery to actually vocalize about pain, and so they just hide it. It would worry me that I'm missing something if I manipulated a limb and I got nothing, and yet
Mm.
the dog was still limping on it. So again, it goes back to the question about, is it painful even if the dog's limping?
Mm. Great. Boo, hi Boo. How does this fit in with the evolutionary idea of dogs hide pain?
Hiding pain is not the same as not experiencing pain. And certainly we know with prey animals, they hide pain really well. Really good examples, although not a prey animal, their predators are cats. Cats are really stoical and they can be really, really difficult to read in pain. So we now have these grimace scales, these pain faces in cats, which are really, really subtle differences in the position of the ears and the whiskers and the mouth and so on. And mice are very difficult to read as well. Horses are notoriously difficult to read, again. And we do now have these grimace scales in horses where people have analysed their facial expressions, and we've got some kind of inference from that. But hiding pain is basically an evolutionary thing to not stand out in a crowd, if you like. You don't want to be seen as the weak wildebeest in a herd of wildebeest because you're going to be picked on by the lions. So I think in evolutionary terms, stoicism, even humans are stoic. I'm stoic. I don't go around, if I pick something up and I get a shot of pain up my arm because I've twisted my thumb, I don't scream out in the shop and say, "Ah, that was horrible. That really hurt." I'm stoical about it because I'm kind of measured. So I think we're all a bit stoical when we need to be. That doesn't mean it doesn't hurt.
So how do we help our vets help us and our dogs? I guess that's about what you talked about earlier about us being make sure that we can kind of do our observations and make sure that we can evidence based.
Yeah, I think it is. I think it comes back to those four domains again.
Mm.
And I think what that does for me, and in my experience, because I've been using those for quite a long time, when I was in veterinary practice, and I found it really useful because what it does is it gives the carers of animals something they can actually write down and record and then present as their, I can't quite put a finger on it.
Mm.
It helps them answer that question. And I found those really useful. It gives them a kind of voice in that consultation rather than them just plonk a dog on a table or a cat on a table and expect the vet to magically use his X-ray hands to find out what's wrong with the dog. The vet does need feedback from the carer as well. And the problem is, as I say, consultations are often tight. They're running late. You get a load of extras in, and for a carer that won't come forward and be a bit more assertive, they can be kind of brushed aside. And as I say, it's not the vet's fault. It's just the way the system works.
Yeah.
Which is why I didn't like vet work and I preferred behavior work because you could give a client as much time as you needed to.
And I guess taking video, photos, and that kind of thing, and that kind of,
Yeah,
that can help.
absolutely. Yeah,
Yeah.
that goes as standard now. You
Mm.
shouldn't even take an animal to a vet without getting video on your phone of it.
Yeah.
In my view, you've really got to get that record. But then there's four domains as well, and you need to tick off all of them. You need to see the ouch. Was there an ouch at some point, i.e. the sensory, oh, and the injury happened if it happened, and then the emotional, what happened at the time of the dog? Did the dog scream? Does the dog sometimes scream if they turn a corner or put their head down to drink or eat something and they scream and run out the room? That's clearly some kind of sign of cervical pain or maybe lumbar pain if they're squatting down or sitting or something like that, or the patella clicks on the knee and they get a sudden jerk of pain. So those are all important for the emotional side. Cognitive side, all important. That's all about mood state. That's all about happiness, well-being. So again, it comes back to recording that. And actually, some of the work that I've been doing for commercial companies is doing just that, recording and building up a picture, a cognitive map picture of animals. And I've done one for dogs, done one for cats, and we're doing one for horses at the moment. And maybe come back and talk about that at some point.
That'd be brilliant.
Separately.
Yeah. Great. Specifically, what is Robert's advice for when we see gait abnormalities, red flags, for pain with abnormal behavioural responses, but nothing showing on diagnostics? Just the kind of central exams. What's the next step?
It's the usual thing. I mean, if there's a problem with the animal's gait, I think physios are really good at picking these kind of things up. Veterinary physios. A lot of vets now work with physios, and because they can see an animal in a much more open environment and have more time to do it, and they're used to handling these animals because they're often behaviorists as well, and they're really good at picking up these kind of things. So I think if you're worried about gait, then tick that box as a concern. You can't quite put a finger on it, and keep pressing.
Yeah.
Because just because you can't, it's the usual thing in science, isn't it? That a negative doesn't prove anything. It's like trying to disprove or prove that God exists.
Mm.
I'm not making a religious comment there. I'm just saying it's one of these things you can't prove it's not a negative.
No,
I think one should always suspect, and it comes back to Jonathan Birch again. Precautionary principle: assume it's there, and then try and disprove it rather than the other way around.
And I have to say, I don't know whether you're listening in, Kate, but Kate Davies, my local physio, and I'd be lost without her, Robert. I think, to get her input on these things, and
Yes.
the vets that I work with who are sensible and value that kind of input. Kate can do a huge amount in that hour with her observations and just
exactly
the kind of minutiae of some of that movement. And Julie Robertson over in Dogs to Care, we had a chat a couple of weeks ago, actually looking at posture, even just from a dog stood still. What you can take from that. But okay, so last one, because we're kind of over a little bit here, but that's okay. It's been a great conversation. How do connective tissue disorders, e.g. hypermobility, Ehlers-Danlos syndrome, change the pathway of the pain signals?
I don't know if it interrupts the nerves in some way. If you've got some kind of pressure on the nerves, I couldn't give you a textbook answer off the top of my head. But anything that disrupts nerve impulses will be pressure on the nerves. And I know that from bike accidents, because I had pressure on a nerve coming out of my spine, my upper spine, and that really affected the nerve signals. I was having pins and needles and tingling and all that sort of thing down in my fingers.
Great, thank you, Robert. So just copy this here. So somebody mentioned about the fact that canine arthritis management have great free resources available for everyone to record dogs' changes, etc., and then take these details to the vet. Thank you for that, Leslie. And that's a nice point to remind me that CAM are doing another brilliant chronic pain symposium next year. I'm just going to put the link into the chat there, which is 25th to 28th of April. Now, this is CAM bringing together lots of different people talking about pain from different angles. Actually, it's free, which is amazing. Or if you wanted to have, it's over 4 days, 25, 26, 4 days, 5, 6, 7, 8, 4 days. My brain's gone. Anyway, 4 days. So it's a lot of content, but you can also pay for it, which gives you access to all of them for a whole year for just 75 quid. So do check out the Chronic Pain Symposium. And I think, Robert, especially for us behaviourists and trainers, we do like to have a bit of a whinge sometimes about the veterinary system, which sometimes that might be very valid. But equally, I think the onus is on us to learn more ourselves too. Actually,
absolutely. This is the point I tried to get across. I think it's really important for the person with the responsibility for the animal, not just dogs, whatever animal you've got, really has to take some responsibility for that. And I think that there is a tendency for some people to just give it all the responsibility onto a professional, be that a behaviourist or a veterinarian or physio or a nurse. We've really got to encourage people to take some responsibility themselves, which I'm hoping that 4 domains model will do. It'll kind of open the door. And as I say, I'm very happy to expand that with other behaviourists, or some kind of tool that we can then put out there.
Yeah.
Just a quickie before we go. The early bird for CAM is Monday, at their time.
Right.
Monday the 9th. I'm looking at my calendar. Then the early bird cost of that, if you want the whole year's worth, expires, and you have to pay the whole lot, which is about £120 or something.
It's still great value. Now's the time to get in there for sure. Yeah.
So if you're going to buy your tickets, buy them quickly over the weekend. Don't delay, don't miss it. It's really well worth going to.
Yeah.
Huge, broad spectrum of disciplines in there. And Sam, I don't know if Sam Lindsay's talking there as well. She might be.
Great. I didn't realize about the early bird, so I shall look. I need to maybe share that into the groups. Actually, I'll do that tomorrow. Brilliant. Well, that's been amazing as always, Robert. Thank you so much.
And you, Andy. Yeah, thank you. Always lovely talking to you.
We're going to be seeing a little bit more of you, obviously, because you and I are going to be working on a little project with Pet Remedy, which will be kind of in this group. So look out for that. And and if you're in the UK, stay safe this weekend with this storm on its way, especially for friends and colleagues in Wales and here in Devon, Cornwall and that kind of thing. But just batten down the hatches as we do. Thank you, Robert. Speak to you soon.
You're welcome. Have a fantastic Christmas, everybody. Thanks for watching. Happy New Year, and keep those pets safe.
Yeah. Thank you, Robert. Thanks, everybody.
Bye. Bye.